Hi, Mike Gibson, Andrew Redington coming to you live from SCAI 2016. Andrew, you just gave the Mullins lecture on how the cath lab should be an area of innovation, not just a dark room where we care for patients. Talk to us a little bit about your vision.
Yeah, so the theme I was given was really more specific in some ways, to talking about how the cath lab has taught us whether we can resuscitate the subpulmonary right ventricle, which is in congenital heart diseases a particularly important ventricle to us. But I used it as a thematic excuse for talking about how I see the cath lab having changed over the last couple of decades. It's so easy to say cath lab. I think we forget that the lab bit stands for laboratory.
Correct.
And before we had interventional catheterization, it was a hemodynamic laboratory, and we understood the mechanisms of failure. We understood, to some extent, the way in which the heart reacted to our interventions. I think
because the interventions were more acute then, and we studied things right in the lab rather than chronic interventions often.
And
yes.
I think there's still a way in which we could use the acute responses to some of the things that we do as natural experiments, as a resource for the hemodynamic understanding, in a way that we perhaps have moved away from. I think almost we've become a catheterization room in interventional catheterization. It's become more like an operating room.
Right.
It's a therapeutic
That's
environment.
An interesting distinction, yes.
And we've sort of lost some of those really hardcore hemodynamic roots.
Yes.
So I think there's a place somewhere in between. Obviously nowadays a lot of what goes on in the cath lab is therapeutic, is interventional at its very core, but to lose what is a rare resource, and that is this incredible hemodynamic milieu that we are directly affecting, and not to measure some of those effects with these new interventions, to perhaps set the scene for the long-term responses, I think is a deficiency. So it was a plea for a somewhat, from an old catheterizer, for a somewhat renewed approach to hemodynamics.
I agree. I think we need to keep those traditions alive. My mentor was William Grossman.
Oh, there you go.
And, a right heart cath with WG was something else. I mean, you had to re-zero after every measurement. When you were getting the pulmonary arterial saturation and the arterial saturation, you didn't get this, and then a minute or two later get the arterial
simultaneous.
It was simultaneous, and the two fellows had to count and say 1 cc, 2 cc's, 3, of the blood, getting it drawn simultaneously.
Well, that's even more precise than me. But the other thing that we have nowadays,
that's an art that is lost.
Oh,
that
absolutely.
Precision.
And, I think that precision is going away, and sometimes we don't even measure them because we're in there to lodge, to deploy the valve. We also have new techniques, of course. The conductance catheter is an incredibly powerful technique that we can now use in humans, just in the way in which we would use it in the animal lab, and validated for use in terms of understanding acute changes in ventricular performance, particularly in the right heart, where we don't have too many good options in terms of non-invasive assessment. I think it's an opportunity lost. It's a catheter, it's just another catheter. We are very tech savvy, I think, in the cath lab now. And again, I think for the sake of a 5-minute assessment before and after we perform an intervention, we're losing a huge opportunity to understand better what we're doing.
I agree. Well, thanks for re-emphasizing the importance of good, precise hemodynamics, how important that 5-minute check is, and what it can mean to the patient and their treatment.
Well,
thanks for joining us here, Andrew, and thanks to all of you for joining us here live from SCAI 2016.